name is Andy Rich. I'm the president of the Roosevelt Institute. And the Roosevelt Institute is a New York City-based think tank and leadership development organization that is focused on kind of reanimating debate of ideas in this country, and is proud to be partnering with Guildhall in sponsoring the Hamptons Institute. I want to thank Mickey Straus, I want to thank Ruth Appelhoff, and I want to thank the underwriters for the Hamptons Institute, Jeff Tarr and Dayton, Ritz, and Osborne Chubb Insurance, for their generous support that made it possible for us to pull this program together. At the Roosevelt Institute, part of our mission, thanks to them. At the Roosevelt Institute, part of our mission is in this reanimation of ideas to support fellows, one of whom was part of an earlier session today with Peter Orszag, Jeff Madrick, who's here, and is a senior fellow with us, looking at issues of the budget and the fiscal challenges, and another of whom is a fixture of this community here in the Hamptons, Ellen Chesler, who very much contributed to making the Hamptons Institute really possible and the partnership with Guildhall, and who is going to focus on another set of challenges, humanitarian challenges that we face today. And she's going to do that in conversation with someone who is perhaps one of the leading international humanitarian figures. Paul Farmer is a medical anthropologist, and he is a physician. He has dedicated his life to improving health care for the world's poorest people. He is the founding director of Partners in Health, which was started in 1987, which has provided health care services, research, and advocacy on behalf of those who are sick and living in poverty in all parts of the world. He began that work in Haiti and has been instrumental in the relief efforts in Haiti since the earthquake there. He's the United Nations Deputy Special Envoy for Haiti under Special Envoy former President Bill Clinton, and has created more than 12 sites across Haiti that are providing services. And it's a unique model in Partners in Health that he'll talk to you about today, where community-based treatment strategies involve the people in those communities in the development and the provision of health care. He holds an MD and a PhD from Harvard University. He is also a professor there. He teaches there, so he both is leading the efforts around the world and teaching on a regular basis and doing great service alongside it. He's the author of more books than I can name, but many of them are actually just outside the door to the auditorium, and I encourage you, if you haven't read one of them, to pick up a copy, and he'll be signing some after the conversation. And there is no better person to have this conversation with Paul Farmer than Ellen Chesler. Ellen Chesler is a colleague of mine at the Roosevelt Institute. She is working on a new book on the human rights legacy of Franklin and Eleanor Roosevelt. She has been, for several decades, working around reproductive rights, and is the author of an award-winning biography of Margaret Sanger called Women of Valor, Margaret Sanger and the Birth Control Movement in America. She too has copies of the book just outside for after the conversation. With that, I'm going to turn it over to my colleague Ellen and to Paul for a great conversation about some of the humanitarian challenges.
Thank you.
Like being in Haiti. Well, thank you so much, Andy, and thanks so much to Mickey Straus and Ruth Appelhoff. It's a particularly great pleasure for me to be here in the Hamptons, where I've had the great privilege of spending 30 years with my wonderful husband, Matt Mallow, and our children on weekends and in the summer. Two of the children are here too, Betsy and Jeremy. I just want to say that I think giving something back to this community, on all of us who have been fortunate enough to be part of it, is just a great thing. And I can't imagine a better person to invite to the Hamptons than Paul Farmer, because he is such an inspiration, particularly to our young people. I am, as you heard, somebody who's written a biography that inspired me to then go work on issues of human rights, and particularly women's health and human rights, with George Soros over the last 10 years or so, and it's that way that I got to know Paul. And so I really thank him for taking time out of what you can understand. It was a very busy schedule to be here with us today. Because I've written biography, I've asked Paul if it's okay if we sort of do this chronologically and begin at the beginning. He's been famously called a man who would cure the world. Andy, who interviews for Marshall Fellowships, those of you who were here this morning heard a Marshall Fellow, Peter Orszag, so you can imagine how extraordinary the kids who apply for these fellowships are. And he told me the interesting story that about 5 years ago, when young applicants for the Marshall Fellow were asked who inspired them, who was their hero, who would they like to be with, they began popping up, many of them, with the name of Paul Farmer. That just moves me so. He is a person who's inspiring a whole generation of idealists. So I'm going to start by asking you, who inspired you? What were the childhood and formative influences that made you want to do this kind of work? Who were your role models?
First of all, thank you all for having me, and Andy for the introduction, and Ellen for doing the homework. I wish you could have given me a heads up on that question ahead of time. I went to Haiti. I went to college thinking I would like to be a doctor. But fortunately, no one ever asked me back then, why exactly would you like to be a doctor? Because I wouldn't have had a very compelling reason. And after Haiti, I knew why I wanted to be a doctor, and also the kind of doctor I wanted to be, which is essentially to take care of people who wouldn't otherwise have access to modern medicine. And so my heroes and inspirations came late, really after going to Haiti, seeing some of the, first of all, I saw Haitian doctors and nurses working in very terrible conditions, as you have in Haiti. And I saw how that could really make them add up somehow to less than the sums of their parts. It seems obvious now, but that was a troubling thing for me because I knew that they were good people and cared about the sick. Otherwise, why would they have gone into this field? But they were unable really to do their jobs without the tools of the trade. And I began reading about people who fought for basic rights for people living in poverty. I mean, I'm sure that's what drew you to Margaret Sanger. And started reading about some of the great figures of 19th century public health, like Rudolf Virchow, who I see you underlining, who actually was also a founder of medical anthropology. This broad view of who gets sick and why and who's shielded from risk. He was one of the forerunners, and also was the opposite of a Luddite. Someone who was really interested in the development of new technologies to move forward medicine and public health. And then, when I went away to study medicine and medical anthropology, I, like everybody else who's a graduate student, became interested in the work of people. In my case, fairly obscure branch of knowledge, medical anthropology, but found academics doing just the kind of scholarly work I want to do, but they were not very often involved in the direct service part of it. So it really wasn't one hero or a set of heroes. It was really learning the limitations of either medicine, public health without the tools of the trade, or scholarly work without the vitality of practice, or the vitality of practice not being very good if it wasn't connected to the more scholarly reflection. That's a very long answer to say I didn't really have one person.
Well, I did read that Virchow once said that physicians are the natural representatives of the poor and social problems must largely be solved by them. That he kind of gave or helped you think about public health as having a moral underpinning, and I love that quote. It does seem to me that health is where human rights begin. You can't really stake a claim on human rights without basic health. It's something we all in the developed world take for granted, but when you do visit poor countries, especially women and children, you see such preventable problems, but no resources to address them. And while it's certainly important to have stability in government, obviously democratic practice, economic development, education, health really is a first line of defense for most people. Talk a little bit, though, about some personal inspiration. You had what you are fond of calling an unconventional childhood. You grew up largely in the South, in the Florida Bayou community, lots of Haitian immigrant workers. How does childhood become the father of the man here?
Well, all I can tell you is I spent my childhood dying and scheming to get out of Florida, and now I'd like to go back there to the same swamp where no one lives. And you're probably going to have some witty aphorism about that, but I did, in retrospect, anyone can take an event from childhood and say, well, this led to that. So those kinds of claims of causality are pretty suspect. But in retrospect, growing up in a large family in Florida, we didn't have health insurance for most of the time, which again wasn't that relevant. We were healthy. We were spared those struggles that you mentioned in passing. One of the things that's been vexing about the human rights community is their slowness. And I'm sure you're writing a book about this now. At least if you're writing about the Roosevelts' contributions to rights, they, especially Eleanor Roosevelt, focused on what FDR called freedom from want. Those rights are critical to survival in the crudest sense in the places where I work. Rural Rwanda, Haiti, which you've seen. We were, having been born in an affluent country, we were spared that struggle, even though we didn't have, as so many Americans didn't have health insurance back then. But we were healthy. We had plenty to eat, plenty and clean water to drink, even if we had to get it through unconventional means. Meaning, we lived in this swamp, which was quite literally a swamp with alligators and brackish water. But you could always stop at the 7-Eleven and fill up the jugs with clean water. So we knew not to drink the bad water. In fact, poor people in Haiti, they don't need to be scolded with public health messages about don't drink water, it's got cholera in it. They'd be only too happy to tell you they would rather not drink unsafe water. And so I think looking back at my childhood, our childhood, I can easily point to those events and say they marked my life. But I grew up with a very large family, and we all went into different lines of work. The brother I'm closest to, my youngest brother, was a professional wrestler on television for 10 years. And I can assure you that although we shared the same childhood experiences, we did not go into the same line of work. In fact, when the Haitians see him and me together, they say, same mother, same father?
Paul's father was a school teacher, but what I'm really trying to do, of course, but I've given him bait since I said my own children were here. I was really trying to get him to talk about his mother, but we'll go back there. Tell us a little about the founding of PIH and its humble beginnings, the key players. Ophelia Dahl, who many of you may not know, is the daughter of the wonderful child author Roald Dahl and Patricia Neal, who just sadly passed away. Jim Kim, who Mickey Straus is very fond of because Mickey's a Dartmouth graduate, and Jim is now the president of Dartmouth, and a wonderful character named Tom White. So tell us a little bit more about that. What was there a handful of people 15 years ago, right?
No, it was 28 years ago, in fact. How about that?
Well, even up till 15, okay, but, 28.
No, I just was thinking, in the year 1983, I met each one of the people you just mentioned, all in 1 year. Amazing. And you can try and be secular in a studied manner, but that was a stroke of good fortune at the very least. I met Ophelia in central Haiti, in Mirbalais, where, as chance would have it, we're now gathered again to try and build back better in Haiti after the earthquake. We're going to be building we are building a huge medical center, in fact. That was in the town of Mirbalais. And then I went to interview at Harvard Medical School in December of that year. And through a connection, my aunt, my father's youngest sister, I met some people involved in a charity, an anti-hunger charity called Walk for Hunger, Project Bread. And that's how I met Tom White, who had given an anonymous gift, anonymous didn't last too well actually, to Project Bread for food insecurity, to fight food insecurity in Haiti. And when I was there, one of those academic mentors that I mentioned, or didn't mention by name, his name's Arthur Kleinman, said, you know, there's this first-year student from at Harvard called Jim Kim. You should meet him. He shares your interests. So all those connections happened
Just by chance.
Just by chance in
Just
1983.
kids. It's like that wonderful memoir, When You Were Just Kids.
Well, you know, some of us were kids. I mean, Ophelia was 18. Jim and I were 23, but Tom was already 60.
I have to mention, because my husband's a Brown trustee here, that Jim Kim as an undergraduate, went to Brown. So, contrast PIH then with what it looks like now. 12 countries, 5,000, 8,000 employees, or something like that. A budget of, what is it now, 85 million? Just tell us a little bit about what it looks like now.
Well, back then, of course, it was just an idea, and it would take a few years to be born. We started in Haiti, as you might imagine, having a there, actually implementing projects. Started with some very ill-conceived projects. A clinic that was built incorrectly. It was huge traffic jams every morning. It was laid out wrong. Medical record system was wrong. That's what it's like. Unfortunately, nowadays, even after all that we've learned, there's still in Haiti, especially, lots of NGOs and goodwill efforts that really haven't learned the lessons that we have. We're trying to codify that now and share these lessons more broadly, as are other groups. I'm not suggesting that Partners in Health is alone in this arena, but to describe what it's like now, it's actually 13,000 employees.
Oh my goodness.
In 12 countries. The two largest projects are in Haiti and in Rwanda, but we work across Latin America, in addition to Haiti, in southern Mexico in the state of Chiapas, in Peru, in northern Guatemala, and in the United States we work largely in the greater Boston area, but some of the lessons that we've learned are being taken to other American cities, including New York. And then in the former Soviet Union, and you know this story because this is how I really got to meet you and Abby Gardner's, who is here through George Soros. There we work still in Siberia. And I saw George Soros not too long ago, and I know some of his friends are here, and I said to him, George, explain to me again how come we went to Russia together to work, and I'm still working in Siberian prisons, but you're not. And then that work led us to Kazakhstan, and then after 2005, we started working in Africa, which is something we dreamed about doing for really 25 years. First Rwanda, then Malawi, Lesotho, Burundi, and then that's it. So I hope we stop and improve the quality of what we're doing and learn from our mistakes and other groups' mistakes, and have I don't like the S word, sustainable, because it gets so abused, but to sustain this work over the long term and draw lessons from it for others.
What is so intriguing to me about Partners in Health and so distinctive is that 150 of these now 13,000, I'm out of date, employees or so are in Boston, the home base. But unlike many, many NGOs that do extraordinarily important work in the developing world, but essentially do it by importing Americans or Europeans, the majority of people who work for you are locals, people you train. Talk a little bit about that and why I think you call it, quite literally, Zamni la Santé, which means partners in health in Creole, but accompanying, partnering, not creating jobs or doing work and taking it away from the country. And talk a little bit more about that.
Well, I have a great debt, as you know, Ellen, to the Haitians. When I was there in 1983 and 84, in between college and medical school, I noticed that the Haitians made fun of the NGOs and in fact, you had the NGOs and international organizations had their own license plates, which said Organisation Internationale, international organization, which the Haitians called Organisation Inutile, useless organizations. So there was a little bit of a hint. And then the other thing that really shaped our work more than anything, though, was we actually worked in a squatter settlement in central Haiti, but the squatter settlement was formed by refugees from a development project, a hydroelectric dam. And it led to a kind of a dark way of seeing development endeavors, which wasn't bad. I mean, sometimes it makes people sound, overly negative, which we're not. I gave a talk not too long ago at the University of Texas, San Antonio, at the medical school. And some kid came up to me, a medical student, and said, "Oh, Paul Farmer." And I thought he was going to say something nice like, "Love your work." He said, I said, "Yes, Paul Farmer." He said, "I thought you'd be a cranky old man." Exactly, and I thought, really, why is that, having never been there? And he said, "Because I've read your books." So I said, yeah, it's a problem. But, I think that tone, the affective tone of critical thinking, for me, came more from Haiti than Harvard. That we would try and build a different kind of organization that would build local capacity, that would create jobs for local people, that would not be guilty of these massive overheads. I just finished writing this book about the earthquake, and it was very painful for lots of reasons, for the reasons of just the proximity to the suffering, but also knowing that a critical assessment of the goodwill efforts that had gone on there since the quake and are going on now would require exposing to some extent the way that it's not just Haiti that needs to be built back better, it's the whole foreign aid machinery. So that was maybe why, and we haven't done a perfect job, that's for sure, as Partners in Health, but we have avoided some of the pitfalls, in part because we were taught early on by the Haitians, you don't want to do it this way.
Obviously, just to defend the old ways of doing aid, people I don't think, had bad intentions.
Yeah.
They simply didn't trust that there was sufficient education, technology, capacity, and didn't want to invest in what it takes to train people. We met, and I remember the conversation very well, the first time I was with you in Haiti, I believe. You said to me, well, why can't a person with a basic education deliver health care? That's the way they did it, in the 19th century in the United States. We've made all of this too technological. We've made it too rigorously specific. And at that time, no philanthropists really were buying into this notion, but fortunately, I was able to convince George to give you a little money, which was a very prescient investment. So talk about how do you train people with a basic education to deliver complex drugs for HIV/AIDS or contraception?
Well, one of the things that we've learned, again, the hard way, is the way that we describe this effort is really critical. And let me just go into a specific example, one of the ones you mentioned. But it's an extremely general example. It sounds specific, but it's not. So the extremely complex treatments for AIDS, in fact, are not very complex at all. And you can actually use what's called a fixed dose combination, one pill, once a day. Now, we weren't using those formulations. They weren't available back when we started. But what we learned from treating tuberculosis, another chronic infectious disease, was that the highest standard of care was actually community-based care delivered by a community health worker. In other words, if you had tons of doctors and nurses or social workers, which we didn't have, even if you had them at your disposal, the highest quality of care was going to be delivered in the communities, in the villages where people lived, by community health workers who were easy to train. In fact, I got into a little bit of trouble back in Boston, because when we introduced the same model, the Haitian community-based care model, into Boston, I got in trouble because I said, all we're trying to do is raise Harvard levels of care up to Haiti standards, which annoyed my coworkers a little bit.
Well, it's a joke, but for those of you who are here this morning, the truth is that if we spent more effort on prevention of illness in this country, primary care, teams of nurses and mid-level healthcare professionals in rural areas. We are beginning to do it in New York, in urban areas, neighborhood health centers, walk-in places. It's cheaper and far less technologically driven, and certainly keeps people healthy before they get sick, and then you don't have to have all the complex treatments. I mean, one doesn't want to overemphasize this. I mean, there are many technological interventions in healthcare that have been extraordinary, and that, as was discussed this morning, we all want to make certain we still have access to. But somehow we've lost this underpinning of public health.
And I think it's a mistake, and to lose that underpinning. And some of you read Atul Gawande, his piece in the New Yorker called "The Hotspotters." Atul and I train together and work at the same hospital. But that model of care is, if you talk to some of the people profiled, is to some extent drawn from this community-based effort in Haiti that went up to Harvard and then out to some of the cities you mentioned. New York was one of them. The other thing is, I think the mistakes we've made have been to call this low tech, because it's not that it's low tech. That's not what makes it good. What makes it good is it's more effective. You get better results. And then you start asking after a few years, why are, when we say medical home in the United States, we're still not talking about home, we're talking about health centers. But what we say is drive this care for chronic disease all the way into the home using community health workers, outreach workers, and then you'll improve the outcomes of any chronic disease, diabetes, major mental illness, AIDS, tuberculosis in my line of work, infectious disease. But really, we have a veritable tsunami of chronic disease coming our way, already upon us, and we don't have a strategy to move that care not only out of the hospitals into communities, but also away from doctors towards community health workers or nurses. And using our system, because we have the United States has some of the very best medical centers in the world, the best ones I've seen, and some terrific doctors. But our system doesn't deploy all of our resources wisely. Again, this is common knowledge to everyone here. I think we can learn things from Haiti about, or the work we've done elsewhere, and about what's now called task shifting, moving the key tasks to other providers.
Mickey Straus, who is really the former person for this series, the chair of the board here, who had the idea to bring ideas to the Hamptons, asked the question of how do you scale up and transform your work from small-scale service delivery to global health public advocate and reformer? How did you get your hands around the thorny issue of convincing the world's public health establishment that you could deliver quality care to the poor and do it in a cost-effective manner? That issue came up around the very thing you talked about, which was the basis for our meeting, the provision of drugs for tuberculosis patients in Russia and then later in Peru. Explain a little bit more of how you transformed through that process of PIH from just a service delivery organization now quite substantial in 12 countries to a global public health force and advocate.
Well, first of all, it's a great question, and one that we struggle with, still have for 25 years, the question of scale, the question of cost effectiveness. And I would say there's been two major approaches that we've taken in grappling with those. One of them has not really been so helpful in terms of suasion of changing minds, and that is critical study of what happens when people talk uncritically about scale or cost effectiveness. That's the kind of thing that I'm interested in my scholarly work is often about that. And I'll give an example. When you hear confident claims that something is or is not cost effective, which is basically the way that a lot of discussions in public health are ended. So if you have a compelling figure say, well, it's not cost effective, then often that's the end of the conversation, not the beginning of one. But what we've tried to do is say, oh, really? Do you know how to cost this? And do you know what are the other effective, interventions? And that's almost shocking to people who say something isn't cost effective. Is they don't expect to be taken on issues such as cost.
But this also strikes me as where you have been so unique, because in addition to your enormous commitment to working with the world's poor, you have this astonishing academic preparation, both in medicine and social anthropology, and the apparatus of Harvard to help you create empirical studies that can disprove these kinds of stereotypes. So talk a little bit about how you went to Peru and showed that, in fact, on a population-based study, one that had a fair amount of scale, you could in fact provide these drugs and solve the problem of not just ordinary tuberculosis, but drug-resistant tuberculosis.
Which, by the way, for all of you, everybody here should know, this problem of drug-resistant tuberculosis or drug-resistant infections is not going away. It will become the ranking problem in infectious disease in the future, if it isn't already. So if you go back to 1945, virtually 100% of staph infections were susceptible, could be killed by penicillin. Now that's about 5%. And that's the way it is in my line of work, whether you're talking about bacteria or parasites or viruses. You put a new treatment out there, and we didn't have any really before the World War II. You put the new treatments out there, and the pathogens, the microbes, they respond genetically. They have mutations that get around those therapies. So the idea that you could just say, well, drug-resistant TB is not a problem was wishful thinking. Now, why was that so persuasive? Because it was really expensive to take on drug-resistant tuberculosis. And it was really an argument about, should we put that much money into problems that really only affect people living in poverty? Now, in New York City, many of you are from New York City and know that in the late 80s, when there was an outbreak of drug-resistant tuberculosis, over $1 billion was invested to rein in those mutant bacteria in New York City. And that was the right thing to do, to make sure people got adequate diagnosis, adequate care. But what happens when you're in a poor community, like a slum in Lima or a squatter settlement in Haiti? You still have the same disease, it's still airborne, it's still treated with the same drug, so you better develop a strategy to take on that new problem rather than say it's not cost effective. And that's the big trap of the late 20th century, was to say anything complex, like cancer cancer in Africa. You don't think people in Africa have cancer? They have just as much cancer as we do here. So these complex and expensive to deal with health problems are everywhere in the world. Now, what we did in Peru was to, again, yes, we wrote the articles and annoyed people by going to conferences saying, well, that's just wrong. By the way, academics, Jim Kim and I said we're going to make a button that says umbrage. It will be taken. So umbrage everywhere, just by saying, well, are you sure that this isn't cost effective? Are you sure that it can't be treated? That was the first thing that we did, was to say, we didn't go out down to Peru and say, oh yeah, we'll show them, we'll treat them and cure these people, just to show the academics how wrong they were. Of course, that wasn't on our minds at all. These are young people dying with a treatable ailment, and we knew how to treat it. What we didn't know how to do then was to codify this in the best way and also drop the prices and influence policy. And that's how we met through George. And I was going around begging foundations for support for this work, and confident that we could manage it clinically, but not confident that we could manage the policy mandarins who said it's not important. They're difficult people to manage, I find.
Well, at the global level and at the US level, politics intervened quickly in your ability to scale up the kind of work you wanted to do. And you succeeded through this fact-driven, empirically based research published in the New England Journal of Medicine and other prominent places, so that the policy establishment could take note of it, in convincing and in changing, essentially, the investment policy of the major health actors, the World Health Organization, and on down. All of the major multilateral and U.S. aid investors in healthcare.
Especially of all places, the Bush White House.
Right. Well, talk
the
about
Bush White House. I got to say, this could be an example where we're having a shortage of policy mandarins was a good thing. It's kind of funny, I thought. But anyway, they in the Bush White House, they became big advocates. Actually, and some of the people who were on our side, I'm sure this is becoming public knowledge, included, some of the scientific establishment, like Tony Fauci. But notice, Tony Fauci, not a public health mandarin, a scientist, doctor, who said, okay, show us that this can be done. We have to do due diligence. And the White House said, prove to us that it can be done. Now, fortunately, again, we said, okay, here are these people who've been on treatment for this disease in rural Haiti for years. And they took the trouble to look and learn and actually come and visit. And that led, the reason I'm bringing that up is that led to the largest bilateral global health program in the history of the world, which was called PEPFAR, the President's Emergency Plan for AIDS Relief. And of course, we used it for all kinds of things. TB control, even, heaven forfend, family planning.
Right.
So,
it was a backdoor around the Bush administration in that respect.
It was, but we said openly, look, we're going to use these resources to strengthen health systems so that you can take on all of the problems that people run into in their lives, whether they're in rural Haiti or in Africa.
Well, and family planning is one of those things. I have to make my paid political announcement here, but
listen, for a good Catholic boy, I'm like Mr. Family Planning poster child.
Well, worked for many years with Planned Parenthood in rural Haiti to model programs, again, that have had great efficacy with women without particularly any education at all, but who are reducing fertility. And of course, the outcomes are very important for women in empowering the women, but most important, the individual reproductive health decisions of women aggregate into major demographic outcomes and economic outcomes for countries.
And also child survival victories for those children they
Absolutely.
do choose to
But
have.
mainly, you can educate your children, improve their health care standards, and employ them, most importantly, so that basically there is now more and more a correlation between lower fertility and better outcomes in countries all over the world. And this is sadly happening just at the time when these issues are deteriorating. The understanding in this country of these issues is deteriorating and is falling captive to the partisanship that we talked about in the earlier session today, the tremendous polarization of this country between conservative few and I think the progressive majority, but you wouldn't always know that we're the majority by listening to cable television. Since you've mentioned President Bush, let's talk a little bit about President Clinton and the role that he played in your life when he left the presidency in 2000 and started the Clinton Foundation and recruited you to work in Rwanda, a country where politics on the ground was complex and difficult, perhaps no more so than Haiti, and you might want to talk about that too, the political complexities that you've encountered trying to do health and human rights are not only at the global and developed world level, but also at the local level. Talk a little bit about Rwanda, talk a little bit about the Clinton invasion of Haiti to restore Aristide, all the things that happened there and what you learned from First Father and President Aristide.
Yeah. Boy, that's a long list.
Yeah, well, that's a long list. Yeah, maybe that's too much.
I will say that to lend some narrative coherence to this, that it was, not that you didn't have narrative coherence.
I didn't.
Matt, get my back on this. I met the Clintons through George Soros again when they were still in, when President Clinton was still in office.
I think we traveled to Haiti
Exactly.
together. We were all.
And I learned a lot about again this lesson from the Haitians back in the 80s. About how development has a dark side, and I doubt I would have used the word policy mandarins if not for Haiti. But I learned a lot in the late 90s about the potential for policy for good. And I'll return to the mid-90s in a second. But when the First Lady, then the First Lady, became a patron of our work around drug-resistant TB, I saw something really remarkable happen because this was in prisons in Siberia. I thought, boy, these guys, and they were mostly guys, are in big trouble because they don't have advocates. That was wrong, fortunately. But I saw, the influence of George and the First Lady on the World Bank, working with the Russians back in the late 90s. Actually, Abby Gardner, who's here with me today, and now I'm happy to say working with me full time on Haiti issues. We met for the first time in Russia in the 90s. When George said, "Okay, you come in and tell me why our cure rates, if this is George talking to me, if as you say, this is a curable disease. How come the prisoners aren't being cured? And I said, let me go find out. And the answer was, unfortunately, because they were getting the wrong medicines. So, and I got in all these policy feuds, which I hate feuds in general. Unlike the kid who said, I thought you'd be a grumpy old man. I save it all for my books, but in real life, I hate arguments. So then I had to get in all these arguments, fortunately not with the Clintons, who were willing to listen, as was George, to the data. And then right after he left office, President Clinton, who I saw at an AIDS meeting, he may still have been president, in fact, said that he wanted to work on AIDS. And it's a completely neglected area in global health, by the way. There was no global fund to fight AIDS, tuberculosis, malaria. There wasn't a single funding mechanism, not one, to bring the fruits of modern technology and science, which had delivered fantastic diagnostics and treatments for AIDS all in the course of just 20 years, not a single plan to roll that out to Africa, which is where the majority of death and dying was happening. So when he said that, President Clinton said that, I said, that's great. We really need you. But we want you to come to Haiti. And so that was the original plan. He was saying, you got to go to Africa. That's where the biggest problem was. And I said, well, we can't go to Africa until we have some strategy to support the work in Haiti, because Haiti was in a tough situation, as you know. In fact, after Clinton left office, there was an active attempt to undermine the Aristide government in Haiti, which came back to power, quotation marks, power, in 2000, at the same time as the American elections. And those two governments, Haiti and the United States, were feuding like crazy. Of course, one big and powerful, one small and weak. And it was really upsetting for me, an American, to be working there then. And that's one of the reasons I said to President Clinton, I'm not going to Rwanda unless you come to Haiti and help us out.
That's what I was trying to get at. Well, I boxed up the question.
He did. No. It's a great question, and I wanted to tie it together. That's what I meant by narrative coherence.
What is so true, though? Go ahead.
I was just going to say, before I leave that, then we went to Rwanda, and again, another experience about policy is having President Clinton on your side in Africa. Good idea. Because he was going in and meeting with all the presidents and ministers of health, and then they would say, hey, you, implementation guy, doctor, go and build the hospitals and train local people, which was what we like to do. So it was a very good experience. And for the last, I'd say we've gotten more done with this trifecta of the Clinton Foundation, Partners in Health, which again, as you point out, builds local organizations. Yeah. Like in Rwanda, it's in Nshuti mu Buzima, which means Partners in Health in Kinyarwanda. I tried to learn all the African languages, didn't do a good job. Finally, I gave up in Lesotho when I couldn't even pronounce the name of the language. But in all those places, we had this trifecta of the Clinton Foundation, Partners in Health, and its new sister organization, and the Ministry of Health. So that was what we dreamed of doing in Haiti, but which was complicated again and again by political turmoil.
Right. So that, I mean, the best intentions, again, sometimes roll up on the rocky shores of political coups, complications. Hopefully...
That's going to be the name of my next book, Coups and Complications.
Before we leave Rwanda, just very quickly, I do think that people are so interested when they meet somebody like you and knowing how you manage to do all these things and also live a life. Your family's in Rwanda, so talk a little bit about the sacrifice that is involved in being both a university professor at Harvard, a UN special envoy for Haiti, a published scholar, and you don't have a managerial role anymore at Partners in Health, which obviously is a huge organization, but you certainly have a leadership role and as a member of the board, a policy role. So what falls out? And I think a little bit of it might be the family that's off in Rwanda, but talk a little bit about that, just in how you...
Well, I mean, initially, when we moved to Rwanda in 2005, 2006, the idea was that I would, this would be my, chance, our chance to work as implementers. And then I'm not blaming the Dartmouth people or Matt, who was related to Brown.
Right.
Anyway, never mind.
Related to
claims of causality. when Jim left Harvard to go to Dartmouth, that was very difficult for us because, first of all, you know, he's the closest friend, and second of all, the way we built this organization is in a very unusual space between the NGO space and the university space. If you look around, there are actually very few NGOs that are situated in or against or abutting universities, which I think is a mistake because we need that feedback loop that comes from research and teaching to make the quality of implementation be better. In fact, if I look at Haiti, you know, and you've been there and we've talked about this many times, if there really are more NGOs per capita in Haiti than any other country in the world, you have to ask, you know, why is it that we add up to so much less than the sum of our parts? And part of the answer to that question is lack of coordination or, you know, poor quality of implementation. But another part of it is that there really isn't enough training and research going on. So creating that space, opening it up, you know, there's a book which some of our mutual friends didn't like very much, which came out last year, but I thought was interesting, called The Crisis Caravan, which is a critique of humanitarian aid, a very, you know, bristling and splenetic critique, actually, but it's still instructive. And the author, whose name is Linda Pullman, the author argues that this is really all since the Biafran War. So that's 1968. That the whole explosion of NGOs is really in the last few decades. So no wonder the quality of the work we do is still pretty shaky, as you've seen. It's all over the map. So back to my hopes and our hopes, which were to work in Rwanda and live there without all this back and forth. That really couldn't happen if we wanted to move forward the academic engine, because as you point out, not that many people in NGO work are professors.
Well, also in recent year, in the last year and a half anyway, a natural disaster and tragedy intervened in your plans to spend more time in Rwanda. So let's use that quickly because we're running out of time here. We want to show you some photographs because I think for all of this talk, which is wonderful to listen to, Paul has a way of using some photographs of the work he does that I think really enrich understanding of it. But just before we get to the videotape, as they say, talk a little bit about the earthquake in Haiti. Maybe we can do a little bit more of that when we get back to questions.
Sure.
That certainly intervened to change Paul's plans considerably. And also, I think, to move you a bit away from health. Is this a fair assessment to a broader understanding of the need for economic development and educational development to buttress healthcare in a country like Haiti? Maybe spend just a few minutes describing the earthquake and the impact it's had, not only on the country. I mean, people have been reading about that, and certainly in this audience, there are any number of people who have been extraordinarily generous in responding.
I bet you most people in this room have been contributing.
But how has it affected your work in Haiti and Partners in Health's work in Haiti?
Well, first of all, I think most of my colleagues who are doctors or nurses, most of them, certainly all the ones I know at Partners in Health, and I mean by Partners in Health, of course, the coalition of organizations we've built up over the last 25 years, they all know that the root causes of our patients' problems are social. So they know that it's poverty, inequality, and that sometimes could be gender disparity, but lack of employment. We've known that. The big question for us has been how much of our time do we sink into healthcare and how much into creating small businesses, for example, or building schools. The answer, I think, would surprise some of the people if you look even prior to the earthquake. Prior to the earthquake, we'd probably built over 30 schools. We had a group of Partners in Health supporters who'd launched, mostly from the business community, actually some people from Long Island, who had launched something called 1,000 Jobs for Haiti in Mirebalais, a town that I'm going to show you a picture of in a minute. So we knew. The question was really, for me personally, how much of my time to spend clinically or teaching medical students and doctors, and how much to focus on these large-scale issues that, you know, you didn't need to be President Clinton to figure out this is what was going to drive forward a reduction in morbidity and mortality.
But it's shocking to me, I must say, as somebody who has focused more on the United States, when I first went into the developing world in the 90s, how little comprehensive community development really was going on. I mean, people ask why we've spent all of this money for over 50 years in foreign aid. So much of it is categorical. So much of it, well, healthcare went here and economic assistance went there. And nobody thought about the fact that to lift people out of poverty, which we've learned in the United States, you would think that we would look at home and apply the same lessons that we've learned to what we were doing abroad, but nobody did. We built up these big aid bureaucracies working with Beltway bandits, as they're called, huge NGOs. One did family planning, and one did healthcare, and one did education, and nobody coordinated. And I think what's extraordinary, and somewhere in this audience, and I hope he'll ask a question, is a member of the board of the Millennium Challenge Corporation, Alan Patrikoff, another Bush era, I mean, and I want to say this to be bipartisan here, since I'm at the Roosevelt Institute, but a Bush-era development, which finally said, maybe the way to do this is to take a look at what a place like Partners in Health is doing, taking a very comprehensive approach to a community, having a bilateral agreement with a government like Rwanda or like Haiti, building into that agreement not only allocation of resources that are determined in the country itself, not in Washington, as to what you need for education, what you want for health, what you want for economic and job creation, but also building in covenants about corruption, about gender balance. I mean, a favorite subject of mine, the MCC does have covenants that demand that women in these countries get some of the aid and have some of the say. So I'm so thrilled to see that continuing more and more, and I think it is beginning to influence also what the UN is doing now in terms of the Haiti Reconstruction Authority, taking much more community-based, local-based, comprehensive approaches to the development and to the use of this money, which I hope will have a better outcome. What do you think about that?
I think it will. It's been painfully slow in Haiti. For example, I'll give you some numbers. Probably maybe Abby or Jenny Block, who's here with me, would know the number, but only about 20% of the rubble's been cleared. So after 15 months, that means that it's impossible to rebuild. But part of the pathology is that the rules of the road for foreign aid and development aid are just completely incorrect. And you got to go back to look at some of the legislation from the 60s, which set up the Beltway banditry that would happen, whether we will or no. In other words, regardless of people's
again, people don't have bad intentions.
Yeah,
I mean,
exactly.
they're very well intentioned.
Exactly.
That's the thing. And
so
just things go awry.
It's structurally set up the wrong way, and it can be fixed. I mean, that's the great thing about human folly is if it's human folly as opposed to some act of nature, then it can be fixed. So I'm optimistic that even if it's, by tweaking the system to make it better, or by, the much more desirable outcome, which is to rebuild it completely, that we can build back Haiti better by building back foreign assistance better. And you mentioned one example, like gender equity. Of course the rules can be rewritten. Of course there could be a limit on overhead. People are very shocked to learn that most of these health projects have over 50% overhead. This is too much. If you have 50% overhead, then how are you going to, build local capacity? You just don't have enough money in the budget that's going into the, and creating jobs locally. One last figure, and then I can certainly, we can discuss this, but, in the first of all, more than half of American households donated to earthquake relief in Haiti, which makes me very proud as an American. So that is a stunning figure. And that says to me there's no shortage of goodwill, and people are discerning. They know that Haiti's in a particularly bad situation, and more than half of American households. In the first couple of months after the earthquake, $1.3 billion of aid went to Haiti. And guess what fraction of it went to the public sector? So in public health, you need the Ministry of Health. In public education, you need the Ministry of Education. But the number is 0.3%. I had gone to Washington, the Senate Foreign Relations Committee, and I testified on January 26th or 27th, so 2 weeks after the quake, and I said only 3% went to the public sector. I was off by a factor of 10. It's 0.3%. So you can't rebuild public capacity in healthcare, education, or water. That's why the cholera epidemic
This is a
slammed
huge
us.
conundrum, and I think very few people understand that the tragedy was so great in so many respects, but one that is totally ironic is that the epicenter of that earthquake was the Haitian government buildings, and there's not one left standing. I mean, we've seen many pictures of the palace, which is a beautiful building in rubble, but virtually every ministry was destroyed. There's not a computer, a piece of paper, and many, many lives lost. I was at
20% of the civil servants died.
Right, a conference in New York on Thursday with Haitian nurses trying desperately to rebuild nursing education, which is hugely important to the delivery of health care. And of course, 300 nursing students in one building were killed in several minutes. So these are overwhelming problems. I think the good news is, as you said, so we go to the photographs without being totally despairing, that the generosity that was shown in this country in the private sector was extraordinary, and that despite the fact that Americans are terribly concerned about fiscal austerity and the need for fiscal austerity in this country, and that there's a concern about too much government, if you ask most Americans how much we spend on foreign aid, they'll tell you, oh, probably about 12% of GDP or even 20% of GDP. And if you ask them what they think it should be, they'll say, well, maybe, cut it in half. And of course, we spent less than 1% of our GDP on foreign aid. So there is actually, with education, room for growth, I think.
Yeah.
And if that happens, and if the money is better spent, I think maybe we can be optimistic that we'll play an even more important and valuable role in the world. And I should say also that for all the mistakes that have been made, there are some real success stories. I mean, I'm one of the people who believes that American support for family planning in the world has been a huge success story of the 20th century that needs better telling. Similarly, our support for human rights and democracy. The world's a more democratic place. It's having very many growth pains, democracy around the world, but it's slowly taking hold. With that, should we let you show a few photographs, and then we just have about 5 minutes to look at photographs, and then we'll have questions.